Hi guys, welcome back. So for today's video, it's going to be a bit different because I got a question or just a request from WhatsApp from one of my really good friends asking if I could just show you guys how I would approach paper 1 for the PD final exam. So this past paper I think is from like a year ago or maybe a few years ago. I'm not really sure, but I have the paper right in front of me and we'll go over this together. Okay. Right, so starting with the cardiovascular system. So precordium palpation, thrills, lifts and heaves, and PMI with normal diameter and distance from midsternal line. Right, so, sorry guys, I'm losing my voice today. Okay, starting with precordium palpation. So lifts and heaves are sustained impulses generated by enlarged chambers of the heart, like enlarged atria or enlarged ventricles, that would rhythmically lift our fingers when we palpate them. So essentially what we do is we just place our fingers flat on the chest and feel for any heaves or any lifts. Okay, and thrills are just palpable murmurs. So we just feel if we can feel any palpable murmurs, and if we can, then we auscultate the same areas just to check the type of murmur. Okay, PMI with normal diameter. Okay, so the PMI, usually the point of maximal impulse, usually is at the apex of the heart. So the apex of the heart is on the left side, midclavicular, fifth intercostal space. Okay, so this is in normal people. So the PMI can be displaced or can be found on like other areas if there are any like pathologies present. So for instance, in the case of dextrocardia or situs inversus, the PMI can be felt on the right hand side because in dextrocardia, recall that the heart is basically on the opposite side, on the right side. And in situs inversus, not just the heart but other organs are kind of like transposed to the other side. So the stomach and the spleen are like on the right side. So in those cases, we would feel the PMI on the right side instead of the normal left apical side. Also in pregnancy, the PMI can be moved higher up because obviously the uterus is pressing the diaphragm up, which then presses the heart higher up in the thoracic cavity. And it says with normal diameter. So the normal diameter of the PMI, if the patient is lying supine, the normal diameter is 1 to 2.5 centimeters. And this may feel larger if the patient rolls to his or her left lateral decubitus position. So for the second component of the cardiovascular system examination, it says we need to measure Jvp, including the correct degree of head placement and of ruler and rectangular object. Right. Okay, so for Jvp measurement, the Jvp gives us like a very good indication of the pressures in the right atrium. So for Jvp measurement, we need to lie the patient supine, elevate their head up to 30 degrees. This is our starting point. I'll explain later some of the conditions or situations where we need to move the head up or down. So we start with laying the patient on an examination bed, tilting the head up to about 30 degrees, okay? And then after that, what we need to do is we need to basically ask the patient to turn away from the side that we're examining. So we need to check some of the other structures like the carotid pulse and the external jugular vein and the internal jugular vein. The internal jugular vein is quite difficult to locate, this is actually the vein that we need for this test. But the external jugular vein runs parallel to this, and it's actually a lot easier to find, and the carotid as well. So firstly, we need to distinguish the carotids and the external jugular vein from the internal jugular vein, which is the one that we need for this examination. So just to run over it really quickly, carotid pulsations would have a palpable pulse, so we can actually feel the pulse of the carotids, whereas Jvp pulsations are non-palpable. And the carotid pulsations would be unaffected by like the head position, the fluid status of the patient as well as the patient's respiration, whereas JVP pulsations would be affected by all of those. So, for instance, the fluid status, if the patient is hypervolemic, the JVP would increase. And if the patient is septic or hypovolemic, the JVP would decrease. Also, in inspiration, JVP would decrease. And if we elevate the head of the bed, JVP falls. If we lie the patient a lot flatter, JVP, the point of oscillation would increase. So, again, the carotids would be unaffected by all of these factors. And the carotid would have 1 pulsation per heartbeat. JVP would have 2 waveforms or 2 pulses per heartbeat. And finally, if we press on the liver on the right upper quadrant, this would transiently increase JVP, whereas carotids would be unaffected. So this is called the hepatojugular reflex. Hepatojugular reflex. And okay, so once we've distinguished between the carotids and the JVP pulsations, what we can do to help us visualize the highest point of oscillation better is shine a pen light or a torch diagonally to the patient's neck. So this is called tangential lighting. So this would help us visualize those the oscillations of the JVP. Once we've located the highest point of oscillation, what we need to do is we need to extend like a straight edge, so like a thumb depressor or a ruler from the highest point of oscillation, and we need to put our ruler vertically up, so vertically from the sternal angle. So the sternal angle is that bony ridge where the manubrium joins with the body of the sternum. So we just put our ruler vertically from the sternal angle, and it's not going to be accurate, guys. I'm just trying my best to demonstrate. And then we locate the highest point of oscillation, and we extend a straight edge from that point. And you know, like that bit where they cross, so that vertical distance from the sternal angle, is the JVP measurement. Well, it's half of the equation. So that measurement, so JVP measured from the sternal angle has to be less than 3 centimeters. And we add 5 centimeters to this number to calculate the actual JVP. So the JVP measured from the right atrium, okay? And this number has to be less than 8 centimeters. Okay, so the next part is about the respiratory system. I apologize, guys, I can't really stare at the camera because the sun is shining directly into my eye. So, respiratory system. We need to do inspection, general inspection, so color of the skin, signs of central peripheral cyanosis, clubbing of nails, type of breathing, position, ratio of inspiration to expiration, and then that's for 2.5 points, and then anterior and posterior chest inspection, including shape, movement during breathing, asymmetry, deformity, and scars, again for 2.5 points. So it's essentially lung inspection for 5 points, which is quite a lot. Right, so let's start with general inspection. So the first things that we look at is basically like the rhythm and the type of breathing. So is the patient showing any respiratory distress? So respiratory distress could be like, they can be tachypnic, so they're breathing, you know, in a rapid pace. So we can measure the respiratory rate to determine if they are tachypnic, if they have any respiratory difficulties, or if they are in respiratory distress. We can look at the color of the skin as well. So if they're pale and in worst cases cyanotic, then again this indicates that the patient is not breathing as efficiently as possible. And we need to investigate causes for this, like maybe an obstruction in the airway or something like that. And we need to listen, just generally listen. You don't need to use a stethoscope for this. Just listen to audible breath sounds. For instance, stridor. Stridor basically indicates like respiratory distress, and like it's like there is an obstruction. Sorry guys, I had to move places because I was just boiling. Right, so another thing we could do for general inspection of the thorax is just listening to audible, you know, breath sounds. So we don't need to use a stethoscope for this, so we can just listen for signs they are struggling to breathe. For instance, like stridor. So stridor suggests that the patient is in respiratory distress because there's like an obstruction in the airway. We could also just listen for any wheezing. So wheezing is common in patients with obstructive pulmonary diseases like COPD, and this indicates the narrowing of the airways. Also, for general examination, we could look at the AP diameter, or the anterior posterior diameter. So essentially what we're looking for is a barrel chest, which means that the AP diameter is greater than 0.9. So the paper says ratio of inspiration to expiration. So okay, so if indicated, we can use a stethoscope to auscultate the chest and listen for breath sounds. So normally breath sounds would be vesicular, which means that the breath sounds are like low in pitch and soft, and inspiration is longer than expiration. If inspiration equals expiration, then this is called bronchovesicular. Or if the expiratory sound is longer than inspiratory sound, then this is called bronchial breathing. Right, what else? Okay, I think that's it for general inspection. Okay, so we need to inspect the anterior and posterior chest. So let's start with the posterior chest. So posterior chest inspection, we need to look for any deformities in the chest or the thoracic cavity, any scars from previous surgeries, if they have chest drains attached to them, any asymmetries in breathing. So this may indicate like a large pneumothorax or just pleural effusion if the breathing is not symmetrical. What else? So I think that's it for posterior chest. Okay. So for anterior chest, again, it's kind of similar. So we look for deformities in the thoracic region, any asymmetries in breathing, any scars from previous surgeries, any lesions, any drains attached, any evidence of respiratory distress such as retraction. So retraction is common in asthmatics, so when people get really bad asthma attacks. So what happens basically is like, so there's two types. There's substernal and I think intercostal retraction. So substernal retraction is that little bit of like dip there. So it goes even deeper because the patient is struggling to breathe. And intercostal retraction basically means that the spaces in between the ribs, they appear deeper because the patient is struggling to breathe. So the only ones I can think of is inspecting tracheal deviation. So this might be relevant to this examination as well. Sorry, itchy. So tracheal deviation, basically we just look if the trachea is still in the midline. If not, then this could be due to atelectasis or a large pneumothorax. And finally, we look for the use of any like accessory muscle, which then indicates that the patient is struggling to breathe. Moving on to the next one, we need to do liver percussion palpation and the Murphy sign. So percussion, it says liver span on midclavicular line for 2 points. So for liver percussion, we percuss the liver basically to estimate like the borders of the liver, or basically the size of the liver. So we can start from the midclavicular line. So the liver is on the right hand side. So we start from the we locate the midclavicular point, go down to the level of like T4 or something, and we percuss downwards to find the upper border of the liver. So we do that by placing, I'm not going to be able to do it properly, but I'm just going to show you guys. So basically we place the distal interphalangeal joint of our fleximeter finger onto the structure that we want to percuss, and our flexor finger, which is like the middle finger of the other hand, we just briskly tap the distal interphalangeal joint. Yeah, we just go down, just to so when you're doing this, you need to listen for when the resonant sound of the lung changes to dullness, because that means that you've hit like the liver at that point. Okay, so you just midclavicular, starting from like let's just say middle, like nipple line T4, go down. And then let's say that this is where I first hear the dullness and all of this is resonant. I mark it there. And then what I do is I go down, again midclavicular to the level of like my umbilicus, which you can't see. And then percuss up. Again, I'm not doing this properly, guys. I'm just trying to show you. So you need to listen for when the tympanitic sound of the abdomen changes to dullness, which means that you've hit the liver at that point. So you mark that as well. And these 2 points that you've marked, is this the length or the width? I'm not really sure, but this bit there, from the top border to the lower border, has to be between 6 to 12 centimeters, okay? Otherwise, it would count as an enlarged liver. Okay, so that's it for the liver span percussion. So palpation of the liver, it says including the hooking technique. So firstly, we need to start with just our fingers. It's gonna be hard to demonstrate, but because I'm doing it to myself. So we just try, because the liver, most of the liver is covered by the ribs, so you can't really feel the whole of it, but you can sometimes feel the edges of the liver. So we just try go underneath the rib, ask the patient to breathe in and out, and feel the edge of the liver brush against your finger pads as the patient, inhales and exhales. And the edges of the liver should feel smooth and like not nodular, Also, if you can't feel the liver this way, you could use the hooking technique. So that just involves using 2 hands and like hooking the costal margin, and again asking the patient to do the same, so you could feel the liver border, making sure that it's smooth and not nodular. So Murphy's sign is the last part. So this is for 1 point. So Murphy's sign is a sign for cholecystitis. So cholecystitis is the inflammation of the gallbladder. So the gallbladder is on the right upper quadrant, similar to the liver. So what we do is we can use the hooking technique here as well. So we hook it there and ask the patient to take a big breath, well, inhale and then exhale. Positive Murphy sign would be the rapid cessation of inhalation, because as that gallbladder, that enlarged, that swollen, inflamed gallbladder brushes against your fingers, it would be painful. So the patient would actually stop breathing. So that's a positive Murphy sign for cholecystitis. So the next one is the nervous system. So we need to examine cranial nerve 2, 3, 4, and 6. So cranial nerve 2 is the optic, cranial nerve 3 is the oculomotor, cranial nerve 4 is the trochlear, cranial nerve 6 is the abducens, okay? So cranial nerve 2, the optic nerve, so this mediates our sense of vision along with the other ones as well, because they all work kind of together to perform some of the functions of the eye. So specifically for the optic nerve, cranial nerve 2, what we need to do is we need to examine like visual acuity using the Snellen test, the like assess the visual fields via confrontation, so using the finger wiggle test or the kinetic red target test. And then after that we need to examine the optic fundi using an ophthalmoscope. So firstly we look for that red eye reflex as we shine the ophthalmoscope light into the patient's eye. We need to see the red eye reflex in both eyes. If that's negative, or if you don't see the red light, then that's indicative of retinoblastoma. And then we move closer into the eye and look at the structures inside the eye using an ophthalmoscope. So we look at the optic disc and the physiologic cup. So basically to locate this, you just follow the vasculature, and hopefully it would lead you to the optic disc. So the optic disc is round and yellowish orangey in color. And the physiologic cup is like it's less than a half of the size of the optic disc. If that's enlarged, then that's pathological, might indicate like glaucoma. So the things that you look for in the optic disc are like its color. So pallor suggests like optic atrophy. Swelling of the optic discs indicate papilledema. So that's usually due to increase in intracranial pressure. Cranial nerve 2 and 3 can be examined together as well. So the optic nerve and the oculomotor nerve can be examined together because they work closely together. So the way that we examine these is that we look at the pupils. So we inspect the pupil sizes, and they should be symmetrical. Sorry. Okay. But sometimes there might be a discrepancy between the size. So if there is a difference of greater than 0.04 millimeters between the two pupils, then this is medically called as anisocoria. So anisocoria is just different pupil sizes, which does not necessarily mean that it's pathological. So this can be physiological. So I think like 1 in 5 people have unequal pupil sizes, or like 38% of the population, I think. But it can also be pathological, so it can indicate, lesions in those cranial nerves. And then we inspect the pupil for like the light reaction. So we shine like a pen light, like on one eye, and we should observe direct constriction of that pupil, as well as the consensual reflex, or the constriction of the other pupil when you shine light on this one. The other thing for pupil is testing for near reaction. So asking the patient to look at your finger like maybe 10 centimeters away from their face, and then looking at some object at a distance behind that finger, and then focusing on that finger again, and then looking at the distance, and then focusing on the finger again. And what you should observe is the constriction of the pupil as the patient attempts to focus on a nearby object after looking at a far object. Okay, so that's the normal near reaction response. And then for testing sorry, I need to drink. Whew. Sorry guys. Okay. 2 seconds, sorry. Alright. For testing cranial nerves, 3, 4, and 6. So 3 is again the ocular, 4 is the trochlear, and 6 is abducens. So we can test for the extraocular muscles of the eye. So basically we firstly need to check 6 cardinal directions of gaze. So we sit in front of the patient and ask them to we can stand actually, but just be in front of the patient and ask them to not move their head and follow your finger just with their eyes. So you just do the 6 cardinal directions of gaze, you just do like an H. So ask the patient to follow your finger just with their eyes, not moving their head. So you just do this kind of slowly. Yeah. And then when you get to the middle, you bring it closer to the bridge of their nose to test for convergence. So that just means the convergence of the eyes as they try focus on your finger that's coming closer to the bridge of their nose. Okay, so with this you need to look for a couple of things. So you need to ask the patient if the patient gets any diplopia or double vision in any of those 6 cardinal directions of gaze, and if so, you need to test if it's monocular or binocular just by covering their eyes. Also, you need to check for nystagmus, or the involuntary jerking movements in the eye, which it's just basically involuntary oscillations of the eyeball. So you need to check if nystagmus occurs in any of those 6 cardinal directions of gaze, and if so, then determine at which direction the nystagmus appears. And so nystagmus has 2 components, so the quick component and the slow component, and you need to check the directions of each component. And just for your information, the nystagmus is named after the quick component. So with nystagmus as well, you need, if there is nystagmus, you need to determine the plane of the nystagmus. So is it horizontal, is it vertical, is it rotary, or is it mixed? And finally, ask the patient to stare at a distant object and note if nystagmus increases or decreases. And finally, for cranial nerve 3, 4, and 6, we can look for the ptosis of the eyelid, or just the drooping of the eyelid. If there is ptosis or drooping of the eyelid, then this indicates cranial nerve 3, or the oculomotor nerve palsy. This can also be seen in myasthenia gravis.